and welcome. Today is the third Friday of this month, and therefore it is the time for Maharashtra State IIP's Case Challenge session. And on behalf of Maharashtra State IIP, myself, Dr. Sunita Inge, welcome all the dignitaries who are present on this virtual platform, as well as all the audience who are watching it on YouTube Live. We are happy to have with us State Convener, Dr. Jaikumar Bhandarkar sir, and Dr. Mahesh Mohite sir, who is the National President of Critical Care Chapter. Our expert for today is Professor C. Srinivasan sir, and all the moderators, both the moderators, Dr. Nani Vadekar sir and Dr. Prakash Vaidya, and the two teams, so who are in the hot seat today. So I welcome you all, and also my respected seniors, colleagues, and friends. Now, I will call upon Dr. Jaikumar Bhandarkar, sir, to give his opening remarks, please. Over to you, Dr. Jai.
Okay, thank you, Sunita madam. At the onset, all the best for the team who have taken the challenge to crack the case. But I will say rather the approach is more important to diagnose the case. And thanks to the moderator and Srinivasan sir for accepting our invitation to get this present in this important event. I not take much of your time. I am the travel, but it is my duty to always to attend all the academic activities we are arranging through Maha IP. And I again give my blessings to all of you for the beautiful session, to have a beautiful session. And again, सगळ्यांना विनंती करतो की उद्या फार अत्यंत महत्त्वाचा क्विज सेशन आपण अरेंज केलेला आहे. त्याच्यात थॅलेसेमिया, सिकल सेल एनिमियावर मोठा क्विज आहे आणि व्हेरी ब्युटिफुली प्रिपेअर्ड बाय आवर टीम. सो प्लीज जॉईन टुमॉरो at 8:15 also. Thank you Sunitaji, and again go back to for the further proceeding. धन्यवाद.
Thank you so much, Dr. Jai. Now I will request Dr. Mahesh Mohite sir, who is the brain behind this concept, to give his comments, sir. Dr. Mohite sir, please comment.
Thank you, Dr. Sunita. Without wasting much time, I think by this time everybody knows the concept. It's all about we have had multiple conferences over the years, maybe over decades. We usually have those panel discussions and cases are being discussed. Most of the times cases are known to the panelists and they are kind of dissected for the understanding or kind of educating the audience. Here we took a concept wherein till this point of time, maybe teams received their invite about 3 days ago, that they are informed long back that you will be taking the case. Dr. Nani Vadekar knew that he's going to present case. Dr. Prakash Vaidya also knew that he's going to present, but when they're going to present, they didn't know. They perhaps came to know about 3 or 4 days ago. Similarly, the teams. And at this point of time also, they don't know who is going to present whom. So that's kind of a secrecy. And honestly, only I know, or maybe Shilpa knows, who is going to present whom. So this is only to maintain the secrecy so that we get absolute academics out of it. And the whole concept is not to crack the diagnosis or to discuss the management. It's all about structured approach. So this is what our teachers like Srinivasan sir, our own teacher, Dr. Ambedkar sir, and all have been teaching for years. They were, rather than spoon feeding us, they were teaching us an approach to a diagnosis. And that's what we wanted to get out of this session. We already had about 4 or 5 sessions. They were absolutely cracker of the cases. And we also know that such a huge hidden talent is there in the periphery who rarely came to the academic dais as a faculty. So this also will encourage more and more people to join as a faculty on the national state conferences. So with that, I hand it over to Sunita madam. Thank you very much for taking this session. Thank you.
Thank you so much, sir.
You, sir.
Thank you so much, sir. Now it is my pleasure to introduce our respected expert for this session is Professor C.V. Srinivasan from Chennai. And Professor C.V. Srinivasan sir has been the director, professor and head of the most prestigious institute, JIPMER, Pondicherry, from the year 2000 to 2011, and followed by his appointment as professor at MGM CRI, Pondicherry from 2011 to 2016. Currently, sir is an adjunct professor of pediatric department at Mehta Multi-Speciality Hospital, Chetpet, Chennai. Sir is a highly respected teacher and who has taught at UG as well as PG levels and continues doing so. During his teaching career, sir has been an examiner at MBBS, DCH, MD, PhD, and even DNB examination. Sir has been awarded with many orations, in fact, 15 to be precise, and he has many publications both in the Indian as well as international journals. Sir has been the founder member of BPNI and is the first editor of BPNI Bulletin. His achievements are many, and I have merely stated only few. But I will now request Professor C. Srinivasan, sir, to express his thoughts and give his blessings. Over to you, sir.
Thank you very much. It is really an honor. And of course, I am a great admirer of Mahesh Mohite, and I appreciate this type of case discussion without anybody knowing who is presenting and who is going to be the person discussing it. And of course, that is the way a case has to be approached with an open mind. So I wish I listen and learn something from these two cases. I'm looking forward to listening to it, and thank you so much.
Thank you so much, sir, for your blessings. Now I will hand it over to Shilpa. Shilpa, please go ahead and introduce the moderators and the team. Over to you, Shilpa.
Good evening to all the respected seniors. So our moderators for today.
I would like the mic to be a little nearer. We usually remind Mahesh Mohite often. Yeah, because I am 75. Of course, I am able to hear, but still, the voice gets.
There is echo.
It is my request.
Shilpa.
Okay.
Yes, sir. So we are very glad to have our two moderators for today. So our first moderator for today is Dr. Prakash Vaidya, sir. Sir is a practicing pediatrician and neonatologist from Fortis Hospital, Mumbai and Child Health Clinic, Mumbai. And he has a special interest in pediatric pulmonology. Sir has been the joint national conveyor of asthma training module, and he has also contributed to various publications and honors. And our second moderator for today is Dr. Nani Madekar, sir. Dr. Nani Madekar, sir, is a practicing pediatrician and neonatologist at Nirmaya Pediatric Nursing Home and Aster Adhar Hospital, Kolhapur. Sir has also been the national conveyor of IIP ALS, has various honors and publications to his name, and he has actually taken our PALS course when I had done it over here in Bangalore. Our two teams for today are from Raigad and from Pune. So welcome. Quickly before we start, each cases will be given 20 minutes and the next 10 minutes will be for the discussion with our experts. Requesting everyone to please keep yourself on mute and also no messages on the chat box. Only the team presenting or team taking the case and the So let's start with our first case. Our first case will be taken by team Raigad, and presenting to team Raigad will be Dr. Prakash Vaidya, sir. Prakash Vaidya, sir, can you please unmute and share your presentation?
Thank you very much. I thank Maharashtra IIP for this invite in this very interesting contest. And I'll share my screen now.
The team Raigad, all the best.
Okay, may I start? Is it visible?
Yes, sir. Not yet.
No, sir. Not yet, sir.
Not visible?
The screen.
Kindly share the screen again, sir.
Actually, let me. Now?
No.
Not yet.
It was visible when I gave a trial. I don't know what happened now. One share.
Initially it came, but now it's not there.
Yeah.
Sir, just minimize your present. Yes,
now
it
it's
is
coming.
visible. Yes, sir, it is visible.
Yeah.
Kindly make it full screen, sir.
Yeah.
Thank you.
Okay, shall I begin?
Yes, sir.
Okay. Good evening. I start my case story. So this is a 7-month-old boy, one of twins, 2.4 kilo LSC sensitivity with an uneventful neonatal period. The baby was breastfed plus top fed. He had vomiting and irritability since the first month of life when they consulted a local pediatrician, and he was started on lansoprazole for 1 month. After that, the parents stopped lansoprazole, and a week later, they went to the local pediatricians for tachypnea, gradual in onset with fever, 100 degrees and cough. This child had symptoms since 3 days. So he had symptoms of tachypnea, cough and fever. Naturally, the X-ray was done, and this is the X-ray here. Is it visible clearly? Yeah. So have a look at the X-ray. Seeing the X-ray, the treating pediatrician admitted the child and started him on piperacillin, tazobactam and amikacin. Since there was no improvement in a period of 5 days, this child was then transferred to our hospital, saying that the child is still in distress. When the child came to our hospital, he was tachypnic with an RR of 60 per minute. Heart rate was 140, SpO2 was 95% on 4 liters of oxygen. SCR was present, ICR was present. The child was very irritable, fever 101, no cyanosis. Breath sounds were well heard and there were bilateral crepitations. And there was no obvious dysmorphic features. And when we went back to the history quickly, we found that the developmental history was appropriate and there was no consanguinity. And this is the growth chart of the child, which shows growth percentile. Length is okay, but the weight was definitely 3rd percentile, very poor weight gain. So my question to the treating teams is, to the competing teams is, what will you do at this point?
Sir, I would like to summarize the case which you have presented.
Yeah.
To start with, 7-month child, LSCS delivery, and history of vomiting and irritability. So it was suspected to have some gastroesophageal reflux, started on Lanzol, and he has a history of a fever that is around 7 months of age. By the time the child has not achieved the weight, although his length was around 25th percentile, and X-ray was suggestive of bilateral fluffy shadows, and there is the child is born of non-consanguineous marriage. So most likely the diagnosis is the child might be having GERD, that is gastroesophageal disorder, with aspiration pneumonia. That is one of the likely diagnoses, looking at the entire presentation. But at the same time, the child is not growing weight. So we need to look for whether this child is having some other underlying disorder.
So your first diagnosis is it's an aspiration pneumonia with an underlying GERD, right?
Yes, sir.
Then why did you not improve on these antibiotics and supportive treatment? That is the question that bothers us.
Yeah, definitely.
And how do we proceed from here? Now he's come to your tertiary care hospital. He's come with this pneumonia that is not responding to the antibiotics that were selected, piperacillin, tazobactam and amikacin. And the child is still tachypnic. So how do we proceed from here? What test would you like?
Sir, we want to know the detailed past history of the story for last 7 months. Any other history of hospitalization? Any other?
I will tell you quickly, there is no history of hospitalization in the last 7 months.
Any history of choking episodes, like feeding difficulties, swallowing difficulties?
No, the child had no dysmorphism. The child had no swallowing difficulties and no choking episodes at all.
Vomiting started since
Vomiting and irritability, but no choking episodes.
Sir, the whole story started since when?
The whole story started around the age of 3 months.
Before 3 months, child was all right.
Before 3 months, he was apparently all right.
And he was on only breastfeed, or he was on?
No, he was on mixed feed, breast plus formula.
Since birth?
Yeah, since birth.
Growth was normal for first 3 months?
Yeah, now actually what has happened is that unfortunately we don't have that record, because he did not really show anybody, or probably the record was not kept, as sometimes it is not kept. But what I understand is that prima facie the child was growing quite well, but I do not have documentation on that, because sometimes even we don't keep, our colleagues don't keep, we don't keep the records so carefully, and they did not show me the papers. So let us assume that he had put on some weight in the first 3 months, and from now on, now of course he's on a very low percentile.
What was the child tachypnic since birth?
Not at all. There was no tachypnea till the onset of the first episode right now.
First episode right now.
Yeah, he had tachypnea only for the last 3 to 4 days with fever, cough, and tachypnea. So it was an acute episode on the background of some possible chronic problem. Okay. Shall I move on?
Yes,
Any
sir.
test that you guys want, which you want me to tell you? How do we proceed from here?
Except irritability, are there any CNS related symptoms, sir?
No, he was developmentally all right.
Okay.
Yeah. So a CT was done, and this was the CT. So it shows definitely bilateral opacities, diffuse consolidation like picture. Now, interestingly, this child's counts were done. CBC was 12,500, very unremarkable counts. His MAN2 was negative, but the gastric lavage showed MTB detected trace in Gene Expert Ultra, trace, with an indeterminate RIF resistance. So an AFB culture was sent for MGIT, and incidentally, this child's PCR was also done from the nasopharynx, which came positive for a rhinovirus. So may I ask the teams, how will you interpret these reports?
Sir, count doesn't show any specific inflammatory.
Count is completely unremarkable. I would go along with you.
There is no was the CRP done, sir?
Yeah, the CRP was done. The CRP was also unremarkable. It was below 10.
Below 10.
Yeah.
Now, after detecting, sir, microbacterium in traces, we need to know is there any history of a cough in parents?
So there was absolutely no history of TB contact in the family at all.
Sir, all reports is inconclusive, sir.
So, yes, at this moment, and what about the PCR? How much weightage will you give to the PCR of the nasopharynx?
Not much, sir, because he didn't presented with any complaint of cold to the beginning, running nose.
Yeah, but rhinovirus is an associated bug for LRTI for sure.
Huh?
Rhinovirus is associated with lower respiratory infections as well.
Yeah. But
okay, so you would just give poor weightage to this report. Like both these reports, you will not go by. Can I take it that way?
It can be, sir. Rhinovirus can be the culprit for this acute episode.
Okay.
But certainly it doesn't go with the chronic history.
Okay. No, but this was a chronic. It was a chronic.
Acute on chronic episode.
But the episode was absolutely acute. So please look at it in that context.
Yeah. Okay, sir. It can be acute on chronic incident.
So anyway, I'm just telling you the story as it happened. This child was put on second line AKT and antibiotics. Now we can dispute this completely, but this is really what was happened. But how do you interpret the Gene Expert report? Do you feel it is a significant report here? Remember, it was Gene Expert Ultra and it was showing indeterminate resistance. So do we go by this, or we kind of ignore the report, or we say yes?
With Gene Expert Ultra, the sensitivity has been increased for the test, but then obviously the specificity has also lost at the same time. Equally. So, and it is detected in trace. So in a given case, when we have two different etiologies, then the obviously weightage goes down. We have already detected the rhinovirus. So,
but may I just tell you one thing, that rhinovirus is a very, very common finding in all biofires. Yes. You do a biofire and 9 out of 10 times you will get a rhinovirus. So rhinovirus by itself is a completely unimportant finding, because every single biofire will have rhinovirus, most of them.
Sir, again, we can think of, like, if we are thinking this report is not conclusive, then we can think of going ahead with a bronchoalveolar lavage and sending it for this thing.
So do you agree that this was drug-resistant TB at all? What is indeterminate tell us?
No.
Okay, we'll go ahead. So what would be your management protocol at this point of time?
We will be doing some bronchoalveolar lavage.
Okay, so I will give you all the answers. This child was put on supportive management. Some antibiotics were started, was given DRTB treatment, ceftriaxone and vancomycin. So with time, the child improved. Follow-up X-ray after 2 weeks of discharge is this one, which was definitely better, and the child was clinically much better. We'll move ahead and we'll give you your. At that point, the BAL was not done because the child was started on some treatment based on a provisional diagnosis, which probably is difficult to justify even at that time and even now in retrospect. But the point is that he was put on this treatment. So he was, things were good for 7 days. After 7 days, child was readmitted, came again with fever, cough, breathlessness. This time he was quite sick. He was put on NIV. His antibiotics were restarted and he was again discharged after a 2-week course of treatment. So what do you think? Is it the possible reason for symptom recurrence and is it the same pathology now?
Sir, in this case, since the child is getting admitted the second time with same lung involvement, that is pneumonia with more severity, then we should definitely think of whether this child is having some immunodeficiency and whether he's having some hospital-acquired infections. That is one thing we should
yes.
of. And what we missed in initial this thing evaluation was a blood gas. What was the blood gas in the
so
initial?
The ABG was not very remarkable. It just showed hypoxia. I think just PO2
Electrolytes.
Blood gas and electrolytes.
Yeah, they were not remarkable. That's why it was not mentioned here. I mean, they did not add anything to the management. There was a mild hypoxia which got corrected after giving oxygen and NIV also. So, and there was no hypercarbia. The electrolytes were normal. So, as you said, Dr. Sachin, that this is the same pathology and you are possibly thinking of either immunodeficiency or you're thinking of, what did you say? You're thinking of
fibrosis.
Chronic lung disease with, because X-ray is showing hyperinflation, whether there is any associated small airway obstruction pathology like ciliary dyskinesias or cystic fibrosis.
Okay. So now I will tell you some of the, but before that, let's go back into the history because when the patient came for follow-up, we thought whether something was missed out in the history. So we went back again and you have again summarized this. There is no history of recurrent fever, no choking, vomiting irritability in the first 2 months, which actually settled down after lansoprazole, no TB contact, no feeding difficulty, other twin normal. So consanguinity wise, we would expect the other twin also to be abnormal to some extent. Underweight child, no pallor, cyanosis, clubbing, no respiratory distress in the past, mild eczema with a cradle cap, other systems were normal. So when we went back to the history, on the basis of what we asked, this did not actually give us any answers. Okay. Now you wanted investigations, so I will give you investigations. So as you rightly said, the DD is chronic aspiration, or was it a structural defect like a TO fistula or a laryngeal cleft? Was it cow milk protein allergy because the child has been on formula feed? Was it an immunodeficiency? So these were the 4 DDs which we chased, and this is the test that we did to rule in or rule out the DDs, and I will just share with you the reports. So CBC-ASR was completely unremarkable again. Specific IG against cow milk protein was done, that was negative, but as we are all aware, CMPA is not diagnosed by specific IG. You need an IgG, which was not available. Then the child, somebody wanted bronchoscopy and BAL. That was done, and we did an immunoglobulin and lymphocyte subset analysis, and I will share these reports with you. So bronchoscopy and BAL was done to rule out structural abnormalities, look for evidence of aspiration. It was normal. There were no significant lipid-laden macrophages. So this was not actually supporting a GERD etiology. Specific IgE against cow milk protein is negative. Immunodeficiency workup was normal. And let me tell you that the MGIT culture came normal. We did a BAL, from the BAL, we did a gene expert, and that was negative. Have we missed something? Can we now, what I would like to throw it open to the teams, that what is the mystery here? Why is the child showing everything normal and yet remaining recurrently sick? Hello?
Antenatal history, previous pregnancies, loss.
No, no, there was no loss in the previous pregnancies.
Go back to the history, sir.
I will go back to the history. This is the history revisited.
History of vomiting and irritability in the first 2 months. So since the beginning, another problem. Other things are not.
What about
Head circumference?
No.
Yeah, the head circumference we already mentioned. It was 25th percentile. The length was 25th. Only the weight was less. And the milestones were normal.
Platelets were normal, sir.
230.
Pardon me?
No, it's a
230.
cystic fibrosis, we should think of, sir, in this case.
Okay, so his sweat chlorides also came normal, though that's not part of the report. That came later, but the sweat chlorides were normal. So that means there's a 95% possibility that we have ruled out cystic fibrosis. At this point, his genetic studies were also sent, but they were not available at this point. But as it happened that we got the diagnosis before the genetic studies. That's a hint to you. So, basically, have I missed something? Let's go back to the history. So any speculation on this? Is it something in the history?
Aldrich can be the possibility.
Sorry?
Viscott Aldrich.
But
the platelets are normal.
Yeah, platelets are normal. There's no eczema also.
Eczema, you written it means
mild eczema.
Mild eczema.
Mild, not that severe eczema. So in a child where there is a bilateral diffuse process, where we know that there is no immunodeficiency, that there is no obvious GERD or even something like something that is causing obvious aspiration of food, that's not there.
Then Wegener granulomatosis can be considered.
Which one?
Wegener granulomatosis.
So would you consider that? But I am just giving you a hint that let's go back to the history, and there is something in the history which we all initially missed, and we really went red in the face how we missed such a history, because that actually gave a diagnosis. So I would like your teams to think a little more. I'm giving you a clear hint that the final diagnosis came from the history, not from the sophisticated tests.
Oil installation.
But so why it should come so late? If they are practicing from the beginning.
Any history of oil installation, sir?
Hello?
That's
a wonderful question. That's a wonderful question, and you have clinched it. There is oil installation by grandmother in the first 3 months of life. And we had even forgotten our resident everyone forgot to take this. So congratulations, that's a wonderful question. So this was actually a case of exogenous lipoid pneumonia caused by inhalation. And a very big round of applause for the teams which are very sharp to get this diagnosis. So history of oil administration related to the time of presentation, clinical presentation of recurrent pneumonia associated with hypoxia or tachypnea, radiological evidence of persistent alveolar infiltrates on chest X-ray, and cytohistological findings are consistent with lipoid content. This we did not find, but we found the rest of the things. And there is a nice article on systematic review on lipoid pneumonia in children, which actually supports. So these are the clinical features of a lipoid pneumonia. There is cough, chest pain, tachypnea, reduced breath sounds, hypoxia, clubbing may be there in severe cases. Chest X-ray shows ground glass opacification, and it's a bilateral disease. And the treatment is antibiotics, oxygen, and assisted ventilation. So we promptly stopped the AKT. We just gave corticosteroids, dexamethasone for 2 weeks, prednisolone. After that, inhaled corticosteroids is also used sometimes. And after that, MTB culture came predictably negative, which is another point I want to make, that Gene Expert Ultra can overestimate, because it's very, very sensitive. So you may get, and definitely when the machine says it forms, it has no resistance. I mean, it is indeterminate. We should respect that and not start AKT, though I will ask Dr. Srinivasan his opinion on this. And this repeat X-ray was normal completely. So the bottom line is that we should interpret reports in the clinical context. And unfortunately, we say history sometimes, investigation often, and treatment always. That is our inverted pyramid of approach today, which is completely wrong. It should be history always. And there is no substitute for a good history. With that, I stop my screen sharing, and congratulations for the team for actually asking the right questions.
Am I supposed to make my comments, sir?
Yes, sir, please.
Can I tell 5 minutes given time? Sir, actually, Dr. Porasu Balakrishnan, he was my professor. He came from Canada AB Pediatrics, and then he joined Safdarjung, and subsequently he was came to Pondicherry as professor head of the Department of Pediatrics. He used to see children below 1 year repeatedly coming with pneumonia. He was wondering, in Canada with cold country, there was no pneumonia that much. And he usually make rounds and then repeatedly ask for child rearing practices. So he found that this practice is there, that every child is having mild running nose, and some doi village lady will come and instill oil and blow through the nose. So he has published it in 1971 British Medical Journal, May, I think 7th or this thing 14th. And he is none other than the nephew of C.V. Raman, and also the brother of astrophysicist, another Nobel laureate, Chandrasekhar. So it is a great discovery, and from then onwards we have been in. We were asked. I was doing a DCH. Those days, of course, ethical clearance was not necessary. We had done biopsy from the lung because it was consolidated area, and of course, the pathological picture has been shown. And typhoid pneumonia was such a important thing. Child rearing practice is very important. And that's how, of course, the child rearing practices is very important for 3 conditions. One is Indian child cirrhosis, is one of the important conditions where how the child is being given, and also another one is sudden infant death syndrome. So the way the child is put to sleep. So we must always go into the history of child rearing practices, and I'm very happy that this case has brought out that important point. Okay, so we must always think there is possibility of, apart from immunodeficiency diseases and structural malformations like tracheoesophageal fistula or gastroesophageal reflux, or even achalasia cardia causing aspiration syndromes. But this thing, it is a wonderful this thing, and you hit the nail on the head and came to the diagnosis. And thank you very much, sir.
Sir, there is 1 or 2 questions if you can answer. Why did the other child not get this, Dr. Nanavadekar sir is asking? And why typhoid pneumonia?
Very good question.
Yeah.
Because the same practice must have been followed for the other
Correct.
child also.
So I will only say that if you walk on the road with the blindfold, you're likely to have an accident, but it's not 100% thing. It just so happened that he escaped. He would have. It was a matter of time.
Purely lucky.
Yeah, so many children are taking peanuts, and some children get aspirated. Okay, so it's not necessary that the other child also has to have that accident.
Actually, sir, another is that why typhoid pneumonia is so late. Abha Patankar is asking if you can answer this question.
Actually, the incidence has come down. Those days, paraffin oil was used for constipation during our postgraduate days. And there was a custom of castor oil being administered to children, especially in villages. So these things, by force, the child will be asked to take castor oil. So there used to be occasional cases of course, this has been reported from other countries also, Egyptian countries and Arabian countries also. But of course, the incidence is coming down, but it's very good that you brought out this case and made its importance felt to all the postgraduates, that you must always go into child rearing practices whenever there is a recurrent respiratory problem, apart from cystic fibrosis and so many other structural malformations and primary immunodeficiency disorders. Thank you, sir. It's a very well discussed and wonderfully within the allotted 25 minutes.
Actually, I would like to ask one question, sir. On 14 months follow-up, whether this child has catch up his growth. Means whether the initial growth failure was attributed to his pneumonia, irritability, or what?
The child was seen in January. This whole story happened in January, and just in the last 5 months, he has put on some weight. See, the part of the reason for poor weight gain was not only the pneumonia, but the fact that they were feeding issues were there. As part of a bad child rearing, they were not feeding the child properly. So after proper guidance on diet, etc., the child is now doing well.
I'll send the article which was published by Balakrishnan to Madam. She can share with all of you. That was one of the first reports of typhoid pneumonia in South India.
Sure, sir. Okay,
One
over to
question.
Shilpa.
My bar didn't show lipid-laden macrophages. What is the diagnostic parameter?
Even now, occasionally we see cases, sir. So in every child less than 6 months, that history has to be always taken. So thank you for bringing out this case and pressing it to everybody so that people know that sometimes it may be customs which cause some problems. We had case of neem oil instillation for children have come with convulsions and Rey syndrome like picture happened, which has been reported by ICH Chennai. So such things happen. So it must always ask what are the practices in bringing up children, and that may give an clue. Thank you so much.
Over to Shilpa. Next case.
Congratulations, Dr. Sachin sir, Prasanna sir, Vipul. And we'll go on to our next case. So our next team to take this case is from Pune. So from Pune, I welcome Dr. Sagar Lad sir, Dr. Rajesh Kulkarni sir, and Dr. Mangalmurthy Bhalera sir. And to present the case, Dr. Nani Vadekar sir.
Is my screen visible?
Yes, sir. It's
Yeah, and I'm audible too.
yes, sir.
Okay,
Yes,
so
very much.
congratulations to team Raigad and all the best to team Pune. This is second time Dr. Mangalmurthy Bhalera and others have in front of me when we did the quiz for antibiotics. At that time also Dr. Bhalera was there.
Yes,
So,
sir. Yes, sir.
yeah, so all the best. So the case over here is, this is just the thing I just wanted to say, together we can, it's the team approach which is going to help us all. So this was a 7-month-old, 20-day-old girl born of non-consanguineous marriage. She came with fever, cough, breathlessness, fever for 5 days, cough for 4 days, and breathlessness for 3 days. And on examination, she was 6.1 kg, height of 69 centimeters. At present, she was afebrile, but there was mild respiratory distress and bilateral wheeze. And she had a palpable liver as well as spleen, which was firm, and significant abdominal distension, which developed over a period of 3 to 4 days of hospitalization. Now, before going to any pictures, would you like to comment the team Pune? What will be your thought process when such a child is hospitalized with you?
So this is a 7-month-old, 7.5-month-old baby with
Yes.
a picture of lower respiratory involvement. Child is tachypneic and there is hepatosplenomegaly. In this child, whether that hepatosplenomegaly is a push down liver and spleen, which many times we can see in bronchiolitis or any pathology. And abdominal distension has developed over 3 to 4 days of admission. So it's a acute distension which is seen during the course of the disease. So it is probably distension, if it was there, would have been noticed by parents prior.
Yeah, it was probably there, but this increased over a period of time. As you correctly said, pushed liver and spleen could be there, but it was firm to palpation. So we really do not know why a bronchiolitis, you will have a spleen and liver which is firm to palpate. But distension, some amount of distension is expected because of aerophagy and tachypnea, but this was out of proportion. Now, let us see the picture of this child.
I would like to have it's quite huge distension, yes. Yeah. And I would like to see hematological investigations as well.
Okay, so we would like hematological investigations also to be seen. Okay.
Clinically, was there any free fluid in the abdomen or any other organomegaly?
We have already said that there was a spleen and liver which was palpable. Fluid, yes, probably clinical examination did not reveal the fluid, but the signs of ascites were not seen. But yes, probably with such a huge distension, there's a chance that this child also had some free fluid in the abdomen. So with this, what would be your thinking process? What would be your thinking process as to what will be possibility? Do you expect only bronchiolitis to cause this, or there's something more to it than what is seen?
No, after looking at the picture, definitely not a bronchiolitis may not be the cause.
Yes.
Child has got a huge abdominal distension. Child looks edematous, puffy, and abdomen is quite huge. And there is edema over thighs also, I can see. I don't know whether there is edema over back.
No, there's no edema there.
We have to look for either hepatic or renal causes for this distension.
Yes, I appreciate the way you have thought, because I wouldn't expect a bronchiolitis to cause such a distension. So there is definitely something more than what is seen.
That was a thought process before looking at the child.
Yes, yes. Excellent, excellent.
Sir, tense abdomen, sir. Is this a tense abdomen?
No, come again.
Is this a tense abdomen?
Yeah, this is a tense abdomen. So there was a past history which was there.
Right.
There was history of fever, cough, cold at 3 months of age, had anemia and thrombocytopenia, was treated at some other place as dengue, but over a period of time, the thrombocytopenia had persisted. So this is the history which is there. We already talked, you all have already talked about the thought process, how you are going to think. With this additional information that this child also has got anemia and thrombocytopenia, what additional thing we will think of?
So this could be an neoplastic or a malignant process that is involving the hematopoietic system.
Okay.
That is a possibility, either a primary or a secondary. I would say primary is more likely. At this age.
But do you expect this child to continue linger for so many months, or say 4 months, because the history was there at the age of 3 months. Now it is 7-month-old child. Do you expect this child to have this anemia, thrombocytopenia persisting without any further
The possibility is
deterioration?
Infiltration of the bone marrow, not necessarily neoplastic. Infiltration of the bone marrow.
Okay, fine.
A storage kind of a situation.
Yes, storage time. Okay.
In this 3-month period, has he had a recurrent fever episode?
No, he did not have. This is the second episode which he has got. And let us see what happened further. Now you can see the picture. There's one more picture added.
Rickets is there.
Excellent. He has got rickets.
Yes.
So does this add to your diagnosis?
I will like whether the child is icteric clinically.
Excellent.
Yes, whether there is a icterus, because if it is icterus, then it will straight away goes to the liver. And then we might think in the terms of either hepatic disease like tyrosinemia, or these are inborn errors of metabolism.
Okay.
Cholestatic syndrome of infancy, which might turn out to be neonatal hepatitis, or maybe, I don't think biliary atresia may be missed by that time, because 3-month child was admitted.
Yeah, this child is 7-month-old. No, so biliary atresia.
No, that's unlikely.
But I think you probably are thinking in the right, because there are rickets which are obviously not missed, and you are talking now about metabolic liver disease in this child. So probable liver disease. So let us see what the investigations have to say. Actually, the child was admitted with respiratory distress. There was some wheeze and abdominal distension. Was treated with for bronchiolitis, which settled down over a period of time. But the parents had not noticed that this distension is there, and it is now increasing. So the question is, will you stop at this or investigate further? Obviously, one will investigate. So what is your take on this? Will definitely investigate further?
Yes, sir, sure.
Yes, excellent. So what all investigations apart from the routine counts and X-ray chest, etc., that will be done. So let us see what we have on our hand. We had a 7.7 hemoglobin, 7,500, 2865, 34, and 1,50,000 of platelet count. The electrolytes were well within normal limit. Ionic calcium was 1.2. Sugar was normal. CRP was negative. Urea 15.91 and creatinine of 0.51. So all this was the first investigation. But as there was a hepatomegaly, LFT was also done.
LFT.
And the serum bilirubin is 1.8 direct of 0.8, ALT, AST 160, 130, 230, and proteins of 3.32, albumin of 2.5, and a PT of 38 with an INR of 2.98. So where does this lead to? You thought of liver process.
Yes.
You have got this investigation.
It's a chronic liver disease.
Okay, so what kind of chronic liver disease?
This is involving the biliary tree because the enzymes are not very high. The SGOT, PT are not very high.
Okay.
They are 200, 230, so they are not too high. There is direct hyperbilirubinemia, and there is a
synthetic function is also affected because the prothrombin time is prolonged and there is hypoalbuminemia.
Yeah. So both these synthetic function is formed. So do you think this child is having a liver cell failure, or this child is doing okay?
No, if the INR is high, so he is landing towards the liver cell failure.
Yes. Okay.
Cautious.
So what other investigation we would like to order at this stage?
Bone marrow will be useful because we had evidence of bone marrow involvement. So liver biopsy might be a dangerous procedure in this child in view of the coagulopathy.
Okay. Before that, some non-invasive investigation would you like to ask for?
Ultrasound. Okay. Markers for liver disease like hepatitis B, C.
Yes.
Gamma GT also.
Gamma GT.
Gamma GT was raised, but hepatitis B and C was negative. Do you expect a 7-month-old child to have a chronic? Because there was no history of transfusion. This unlikely to his, and the mother is also fine.
Unlikely, except from mother if it's.
Yeah, the mother was, she was a hospital delivery which was investigated and was found to have HbSAg negative. So something non-invasive.
Primarily a liver disease that is also involving the bone marrow, that is impacting the bone marrow. We know that liver disease can cause thrombocytopenia and anemia.
Yeah, so this is the ultrasound picture. Ascites was there. Liver was enlarged with core structure. No other organs involved. Spleen was also enlarged. And the kidneys, both the kidneys were enlarged.
Glycogen storage can have nephromegaly.
Excellent. So you think glycogen storage disorder. So now, do you think that this is metabolic liver disease and this is leading to this kind of picture? So what all possibilities will come to your mind?
Tyrosinemia.
You think of tyrosinemia, you think of glycogen storage disorder. Okay. This child did not have any episodes of hypoglycemia. And if you see, the child's extremities are not thin. They are well built. So that was not there. So let us see how we approach to this particular child. So now we have got hepatomegaly, splenomegaly, nephromegaly, and ascites. All this. So let us
have a liver biopsy and genetic workup of this child.
Okay.
Because liver biopsy under plasma cover or to basically under a proper control of bleed, because there is a prolonged PT INR.
Yes. Will you think of storage disorders at this stage?
Yes.
Yes.
Possibly.
Which one?
GST.
GST already not likely because of no hypoglycemia.
No hypoglycemia.
No hypoglycemia. There were no hypoglycemic episodes.
Lipid storage disorders can also.
Yes, so lipid storage disorders. Now over here, the parents were not ready immediately with the biopsy, and this was the thought process which was given. Either it is cholestasis, tyrosinemia type 1, Niemann-Pick, bile acid synthetic defect, the PFIC, paroxysmal disorder, and respiratory chain disorder. So this child was acutely ill right now. Although the illness initially started as respiratory, but even after the respiratory disorder settled down, he looked ill. So these are the things which we thought of: tyrosinemia, urea cycle defect, fatty acid oxygen, glycogenesis, fructose intolerance. Of course, there was no history which would suggest that there was fructose intolerance, galactosemia, but there was no cataract, and respiratory chain disorder. So, and there was a nephromegaly. Now, nephromegaly could be because of polycystic kidney disease, hydronephrosis, pyelonephritis, nephrotic syndrome, and storage disorders. So now where does our child fit? Because he has got liver as well as kidney, which are enlarged.
Possibility of tyrosinemia could be high because nephromegaly, liver involvement.
Okay, so the liver and kidney was involved. So galactosemia or tyrosinemia was very high.
Alpha-fetoprotein, was it high or?
Alpha-fetoprotein was not done at this stage, which was sent. later on. We'll come to that. And so because there was liver cell failure, we already talked about galactosemia and tyrosinemia. Now, this was the way we had thought of, because of metabolic liver disease, liver plus kidney both involved, and there was liver cell failure. So all these were thought of. So this is one of the ways in which we can think of galactosemia if it is between 0 to 6 months, galactosemia, tyrosinemia, mitochondrial cytopathy, or Wolman's disease. All these were thought of. And what would be our investigation of choice now? Because there is hepatomegaly, there is liver cell failure, and there is nephromegaly.
Genetic study, exome sequencing.
Exome sequences. Exome sequences was not done immediately, because for immediate purpose, we did the investigation, and the UHPLC was done, which showed elevated tyrosine, suggestive of tyrosinemia, and it was advised to correlate with the urine succinylacetone. Interpretation was GCMS of urine showed elevated hydroxyphenylacetic acid, 4-hydroxyphenylactic acid, and phenylpyruvic acid, succinylacetone, diethoxyme, so which was suggestive of tyrosinemia type 1. So excellent. Your thinking process was absolutely correct, that respiratory tract infection, yes, fine, it was there, but this child had an out of proportion hepatomegaly and aside the abdominal distension. So the primary process after the bronchiolitis got over, the primary process was this child was harboring some liver disease, and at this stage metabolic disease was likely. With ultrasound finding of nephromegaly and hepatomegaly, you also said that galactosemia or GSD or tyrosinemia should be thought of, and exactly that's what this child turned out to be. So excellent, congratulations on that.
Thank you.
So, yeah. So last time also, Dr. Palera sir, you had cracked the quiz, so the history repeats.
Yes. Yes.
Yeah. The reason for bringing out this case was, this is something which is treatable if there is the parents are willing, then you can treat this child with specific compound in TBC, because otherwise phenylalanine tyrosine will build up. It's not the phenylalanine or tyrosine which is going to create problems, it's the after products, that is acetoacetate, fumarate acetoacetate, and these are going to cause the problems, and this child is ultimately likely to lead into severe liver cell failure and maybe require liver cell transplant. So this drug is going to inhibit that also. Of course, that will increase the levels of tyrosine and phenylalanine in the blood, but that won't be causing any toxic side effect to the child. So the child will be allowed to grow well. So as we have already said, tyrosinemia type 1, the enzyme defect in this child was fumarate acetoacetate hydroxylase. He had severe liver failure. Of course, the child did not bleed, because if we didn't allow him to go up to that bleed stage, and there was a renal tubulopathy, Fanconi syndrome, which is obvious with your rickets which were seen. So he had hepatomegaly. Growth retardation at this stage was not there. Rickets were there. But over a period of time, as the child age advances, because of porphyrias, he can have abdominal pain, neuropathies, etc. So we have already talked about how we diagnose this. High succinylacetone levels, tyrosine may be normal or slightly elevated, and the delta aminolevulinic acid high, and alpha fetoproteins very high. This child had, in fact, high alpha fetoproteins. So the child was diagnosed correctly. And the reason for presenting this child was because NTBC 1 milligram per kilogram will block the accumulation of toxic metabolites. So only if this does not work, then we have to think of liver transplant, and something which can be treated with a drug. That's the reason why we thought of presenting this case. And again, congratulations to the team Pune.
Thank you very much. Thank you.
Yeah. So with this child has got a relatively good prognosis under NTBC treatment. Unfortunately, this child decided not to continue treatment, was lost subsequently, and but the lesson learned was something which is treatable if we diagnose it correctly. So this is the way this works, site of action of NTBC. So toxic substances are not released, and the child will not have the further liver damage. Thank you very much. And I especially thank Dr. Mahesh Kore from Nipani. It's his child. And whenever it comes to inborn errors of metabolism, we always look to Dr. Mahesh, and he's very much there here. I just wanted to have him to say a few words after I finish. Thank you. I'll stop sharing the screen. And I would like the expert, Sir Dr. Srinivasan, also to comment.
Yeah, it's a wonderful case again. And of course, it brings to the point that we must always think of inborn error of metabolism and more than one organ is involved. And this child with hepatosplenomegaly and evidence of rickets. So you have to think of both kidney involvement as well as liver involvement. So naturally, they have hit the nail again on the head by talking about tyrosinemia in the beginning itself. So it turned out to be tyrosinemia. So inborn metabolism is increasingly being diagnosed because of better workup and this thing. And apart from, as we have mentioned, child rearing practices being there. Okay, this is also very important. Okay, in the causation of multi-organ disorders. So it's very important that inborn metabolism, especially if the child is young, with hepatosplenomegaly and liver failure, with rickets, and as you have mentioned, the kidney enlargement, etc. Always think of a disorder where there is this thing, and tyrosinemia is one of the important conditions to be considered in a child less than 2 years of age. Thank you so much. Both cases are very enlightening and, of course, brings to the important point that students must always have open mind. And, they must think of all possibilities. Okay, from genetic to nutritional. Of course, nutrition is very important, and child rearing practices, as you already mentioned, inborn metabolism, apart from infective conditions, malignant conditions, etc. Thank you so much.
May I take a request, Dr. Shilpa, to allow Dr. Mahesh Kore to have a word?
Sure, sir. Thank you so much, Dr. Mahesh Kore.
Yes, this was 5 years back. That's why clinical exome sequencing was not that popular at that time. It was costlier, and this was from poor socioeconomic background. So we have to have only one test. That's why we combine all our efforts to say which causes hepatomegaly, which causes nephromegaly, and which causes liver cell failure. And there are only two things. One is tyrosinemia, and second one is galactosemia. Galactosemia we have ruled out by doing urine reducing substance, by Benedict test, and by strip. So if you don't get any reducing substance there, then you are left with only one thing, tyrosinemia type 1. So we have done only urine succinyl test, and that was given an answer for this child.
Rickets is not so common in galactosemia.
Yeah,
that's goes more in favor of tyrosinemia.
Tyrosinemia, because tyrosinemia involves and damages the proximal renal tubules, and that's why it lands into Fanconi syndrome, and that's why they have rickets because of RTA type 2.
Because in this child, the child was looking chubby. Usually, the children will have failure to thrive.
Absolutely. That's why we thought that it is an acute process and we are not dealing with any chronic process, but it turned out to be a tyrosinemia.
Initially, I was thinking of Wolman's disease.
Wolman's disease. Yeah, Wolman's disease will have a suprarenal calcification and that will give a clue. That was also there, yeah. But X-ray didn't show any suprarenal calcification. Yeah. That's why we.
Characteristic, yeah.
Absolutely. Thank you, sir.
Thank you. It was very educative, and thank you very much for asking me to be there to listen to such wonderful cases and excellent pickups and very well discussed. And both of the teams have got the diagnosis.
Yeah, they got the diagnosis on the fourth slide only. Yeah. Good one.
Thank you.
And thanks to Mahesh Mohite for thinking of such a novel method of introducing case discussions. Thank you so much.
Mohite, sir.
Very important to see how teachers are also thinking. We are always grilling students, but it's very important that how teachers are improving their skills of analysis, etc. Thank you so much. Thank you, all of you, for giving me an opportunity.
Mahesh, unmute.
I hope I am. I hope I'm allowed to participate every time to learn more cases like this. So I request Sunita Engle to give me this thing. Is it allowed for others to come and join and learn?
Welcome, sir. You're welcome. Always welcome.
Thank
I mean, Srinivasan, sir, just for your information, perhaps this is the 5th session. And out of 10 cases, 9 are cracked by the teams. And they were all varied systems, different, difficult.
Yeah, absolutely.
But within 15 to 20 minutes, we provided information with a good approach. So that speaks of two things: the clinical approach and the lab approach still holds true. And there is huge hidden talent in the state of Maharashtra, because we are at present restricted to state of Maharashtra. So many faculty are already sitting idle. They should come on the dais to come with the real knowledge and look at the way we can really create. This is something amazing. And this whole sole purpose, the first case was just on the history, so nicely presented by Dr. Vaidya sir and so nicely cracked by Raigad team. And the second one is again, like what you see as a prima facie, don't straightway go with that. Don't get carried with that. Look for the hidden clues which may be hinting you towards something not obviously seen. And Pune teams did so well. Perhaps on third or fourth slide itself, they got differential of tyrosinemia, which Nani Odekar was shocked because he had to take another 30 minutes.
Oh,
so he had to wind it
in
up
the
further.
beginning, inborn metabolism, Ricketts seesaw once the hand was shown.
Yeah. So that's sole purpose is all about approach. But these guys are coming to the diagnosis as well. It's not just that they gave a good approach, they gave a wonderful diagnosis. Thank you all for. Yeah, of course, Prakash.
We also learned that gene expert we know that it has very high specificity and sensitivity, but it is not 100%. So one of the few cases where gene expert was wrong, if it was positive.
Oh, that's very interesting, because the gene expert ultra, the old gene expert used to have 1 in 133 bacilli. So 133 bacilli per millimeter cube was the sensitivity. This ultra is having 16 bacilli per millimeter cube. That's the reason chances that you will pick up one of the DNA template, which may be senescent bacillus or a dead bacillus, is very high. So especially if you collect a low gene expert positive on a bronchial lavage, you should be extremely careful taking it as TB. And that too coming as an MDR, I think we should be rejecting it unless you doubly cross with a culture or something. So that particular one, that was a good twister, Prakash, you put it, gene expert low as well as a rhinovirus.
Gene expert was done first on GL.
Now, sometimes gastric aspirate may have other anonymous mycobacteria.
So it was a real eye-opener
of course.
that you can't
mentioned tuberculosis,
Absolutely. It was a wonderful case, and of course, Mahesh and Nani, you had a wonderful case that too. In fact, when they came to me, I was wondering who's going to crack these cases. But look at the people; they are absolutely too good. amazing learning, amazing things to learn for all of us. Thank you very much. Thank you very much.
Thank you.
Have a great day and wonderful.
Sir, you will join us for the few cases, further sessions.
Yeah, sure. I am there in Ahmedabad with Prajapati on Tuesdays. Then Thursdays with you people in Amdekar, and of course Wednesday, with Bangalore. So I am on the learning process now again. So learning is never ending. Thank you, madam. Thank you all of you for giving me an opportunity to see such a wonderful, well-informed people, and it's a wonderful experience for me. Thank you.
Thank you.
Thank you so much. And for the vote of thanks, I would request Dr. Neha ma'am to please.
Yeah, thank you, Shilpa. On behalf of Maha IAP, I, Dr. Neha Singh, would like to thank Dr. C.V. Srinivasan sir for accepting our invitation, for being today's case challenge expert.
I must be thanking you for listening to such interesting cases and good work up.
Thank you, sir. You are an excellent teacher, and your expert comments at both the cases were very inspiring and learning. I would like to thank our case presenters, both Dr. Prakash Vaidya sir and Dr. Narendra Nalivar sir, for presenting such interesting cases today. I would thank and congratulate both the teams, Team Raigad and Team Pune, for actively participation, brain hunting. Both the teams were equally wonderful. I would like to thank Dr. Mahesh Mohite sir, who's the backbone of this program, for always supporting all the academic Maha IP programs. Thank you, sir. Would like to thank our Maha IP President, Dr. Niman Gangulia sir, Secretary General, Dr. Amol Pawar sir, and Scientific Convener, Dr. Jay Bhandarkar sir, for giving us this platform. Thank you, Dr. Sunita ma'am and Dr. Shilpa, for moderating today's case challenge. Last but not the least, I would like to thank all the attendees on Zoom and YouTube Live for joining us today. Thank you for joining, and please request to join the next case challenge on July or third Friday of July. Please, thank you.
Thank you. Good night, all of you.
Thank you so much.